everyone. My name is Smriti Awasthi, and I am a recent graduate pre-medical graduate from the University of Texas at Dallas, and I am working at the Heartbeat Clinic in Texas, and this is where I did the relevance of the red cell distribution with and postural orthostatic tachycardic syndrome or postural symptoms without tachycardia patients, a comparative analysis. So a little bit of background, postural orthostatic tachycardic syndrome, or POTS, is a complex disorder that is characterized by an increase in delta heart rate of 30 beats or more while doing the tilt table test. As of recent studies, there are associations between POTS and cardiovascular abnormalities. Postural symptoms without tachycardia, or PSWT, is a condition similar to POTS without a significant increase in heart rate. They are often accompanied by various debilitating symptoms such as dizziness, fatigue, and cognitive impairment that affect their activities of daily living. POTS and PSWT awareness has risen after COVID-19, thus there is not that many studies on the condition. Red cell distribution width, or RDW, is a measure of red blood cell heterogeneity, reflects a potential biomarker in various cardiovascular disorders. By examining RDW in relation to clinical parameters such as heart rate variability, symptom burden, and autonomic function, we aim to correlate its abnormalities in POTS. Abnormal RDW levels have been implicated as a predictor of adverse cardiovascular outcomes and increased mortality rate in various cardiac conditions such as heart failure. Delta heart rate, defined as the difference in heart rate between supine and standing positions, often taken during a tilt table test, serves as a valuable indicator of autonomic dysfunction and cardiovascular responsiveness. By unraveling potential relationships, we aim to better comprehend the mechanisms of the abnormal red blood cells dynamics in these conditions. So then I want to move on to a POTS standard care. So first we have POTS to care for POTS. It encompasses a multifaceted approach that aims to alleviate symptoms and enhance the quality of life for individuals affected by this condition. Approved and customary treatments often involve a combination of lifestyle adjustments, non-pharmacological interventions, and in some cases, medications. So first we have hydration and fluid intake. Adequate fluid intake is emphasized to maintain blood volume and prevent symptoms associated with POTS. Patients are advised to increase water and salt consumption under the guidance of a healthcare professional. Drinks with electrolytes and intravenous drips are typically recommended. Number 2 is physical activity and exercise. A tailored exercise regimen is recommended to enhance cardiovascular fitness and improve orthostatic tolerance. Gradual aerobic conditioning, strength training, and recumbent exercises may be integrated into the treatment plan. Then 3, we have dietary modifications. A balanced diet that includes frequent and smaller meals, and increasing protein intake can help stabilize blood sugar levels and manage symptoms. Avoiding triggers such as caffeine and alcohol and consuming nutrient-rich foods are often recommended. Then we have the 4th one, which is the elevated head of bed. This is where we elevate the head of the bed by a few inches, and it helps prevent nocturnal symptoms and improves morning orthostatic intolerance. And then number 5, medications. So depending on the severity of symptoms, and healthcare providers may prescribe medications to manage specific POTS-related issues. These can include beta blockers to control heart rate, fludrocortisone to increase blood volume, and other medications to manage associated symptoms like fatigue or pain. Now that I've finished covering POTS, PSWT, RDW, and delta heart rate, we can move on to the objective of this study, which was to find out the relevance of RDW in POTS or PSWT patients. So by conducting a comparative analysis of RDW in individuals with POTS or PSWT, the study aims to bridge the knowledge gap surrounding the hematological and cardiovascular differences between these conditions. In pursuit of this objective, our study illuminates the comparison between these variables that in a real-life setting could lead to heart failure. The findings may contribute to improved diagnostic accuracy, tailored treatment regimens, and a deeper understanding of the distinct physiological mechanisms underlying POTS and PSWT. In this study, we are going to use the term abnormal, defined as a low or high heart RDW range, which will be discussed later. And then for methods, a random data set of 158 patients were selected from our heartbeat clinic in Texas. The data was arranged in an Excel sheet where SPSS 29.0 was used to analyze and generate the results, and there were no limitations on gender. And so here we have our results. So among our 158 POTS or PSWT patients, we had 145 or 91.8% that were female and 13 or 8.2% that were male. There were 135 or 85.4% that had patients that had POTS, and then whereas 23 or 14.6% with PSWT. RDW ranges can be from low, which is the 11 to 11.6 range, normal, which is 11.7 to 15 range, or high, which is 15.1 to 24. We had 8 patients, or 5.1% patients that were in the low range, and then we had 34 or 84.8% of patients that were in the normal range, and then 16 or 10.1% of patients that were in the high range. So upon application of the one-way ANOVA on the variables, the p-value that was obtained was 0.138, which is a higher than the standard significant value of 0.05. This leads us to our conclusion that RDW had no statistical relevance in POTS or PSWT patients. Furthermore, elevated RDW levels do not appear to have adverse prognostic implications for delta heart rate in patients diagnosed with POTS or PSWT. Thank you. I'm not sure, actually, yeah. Any other questions? So based off of what I was speaking about with the heart failure, typically when you're hospitalized for heart failure, that we noticed, when we noticed that there was a bad prognosis of heart failure that related to the high RDW range. And so we were seeing if POTS could be considered as type of heart failure, and that's why we were trying to see if the high RDW was statistically relevant in POTS patients, to see if that would be if you had POTS, would that lead to heart failure?